There we go. All right. Well, welcome everyone to our June coffee chat today, Friday, June 13th. I'm so glad to be on with all of you and good to see faces. I'm very excited about today's coffee chat. So we're going to go ahead and dive right in. First, a couple of Zoom features. I know we're all probably pretty familiar with these virtual meetings, but just want to give a quick reminder that we will be using chat throughout the call, live transcription, so you can see the icons, the little CC at the bottom. And especially important today, I want to make sure to call attention to the little interpretation. It looks like a little globe, to make sure that you click that and then select English, because we do have Spanish interpretation. Hi, Isaac. Thank you so much. So I want to make sure that everyone clicks that. And if you are listening in English, please select English or Spanish. So thank you so much. Again, we are recording. There is live transcription. Oh, okay. I thought I heard someone saying something. Yes, and just a quick reminder there, if you are not speaking, if you can just place yourself on mute and we will have time for discussion, but just to avoid some of those background noises while the speakers are speaking. So thank you all so much. Just one quick reminder with Zoom, here we go again, that it is very important, because we do have interpretation on today, that you do select your chosen language. All right, I think we are good there. So I'm going to move us forward to our agreements. So again, these are all wonderful agreements and kind of just a way that we are all together in these meetings. And so today I want to lift up practice active and empathetic listening and sharing. So we will hear a wonderful presentation, lots of really great information. So if you could be here and just listen, we'll have some great listening, some great sharing coming up. So we have a very full agenda and lots to cover. So I'm very excited to move us forward to our introductions. And if everyone wouldn't mind, please chatting in. So your name, where are you, and what do you enjoy most about being involved in the PFA network? So I'll give it just a minute for everyone to find and open your chat box. And if you wouldn't mind chatting in, I'm going to pull mine open too, just for a moment. So if I can see anything coming in, but yes, if you wouldn't mind just chatting in, name, location, and what you enjoy most about being involved in the PFA network. And so again, this is Brittany Jackson. I am in Colorado. We have some sunshine, and I'm so glad. We had rain for the last couple of weeks, so it feels like summer now. It's beautiful. And I really, really enjoy just getting to meet so many wonderful people and hearing all of these wonderful lived experiences from you all, and just seeing each other, the smiles, the connection. Even though we are all over the country, it feels so good to be able to connect. So that is definitely what I enjoy. All right, I see some things coming in. Kate, the energy and enthusiasm. Karen enjoys being with other patients and advocates at each meeting. Rosie, the Wisconsin connections. Livy, the people and the PFA network make me feel so hopeful. Totally, Livy. Victoria, hey, Victoria. Passions of participants. Let's see, Diana, eager to learn more about the PFA network. And Diana, we are eager to have you learn more. So thank you for being with us today. Nadine, learning a new concept or things that are inspiring to you to develop one. Karen, okay, I enjoy being engaged and learning about advocacy initiatives. Hi, Wafa, hearing from others, and Deb, learning from so many passionate advocates. So thank you all so much. Feel free to keep them coming, and feel free to continue to use chat throughout our call today. So without further ado, and hi, Ray, Ray, learning and sharing. So thank you, Ray. All right, so as I just mentioned, I am going to move us forward. I am so excited to be able to turn it over to some of our partners and listen to this wonderful presentation about engaging care partners and shared access to adult patient portal. So we have Rosie Bartel, one of our wonderful PFA Network members, here with us. We also have Kate DeRoche, and we also have Deb Wackenheim with us. And so I'm going to turn it over to you all. Feel free, of course, to give introductions and just dive right in. And I'll also help with technology on this end too. So just let me know when you'd like for me to advance the slides. Wonderful. And Kate, oh, there we go. Yep.
Thank you so much, Brittany, and thanks to everyone for joining us today. We are really excited to talk about some work we've been doing around shared access to the patient portal for care partners. I'll just take a minute to introduce myself, and then I'll let the other folks I'll let Rosie and Deb just give you a 30-second byline, and then we'll just move right in. So again, Kate DeRoche. I am the director of an initiative called Open Notes, which works on increasing transparency in healthcare by getting patients access to their own electronic medical record information. And Rosie? Oh, Rosie, you are muted.
Hi, I'm Rosie Bartel, and I am a widow, mother, grandmother, and an educator. And my background is education, but in 2009, I had a knee replacement that turned into a MRSA staph infection, and that led to 58 surgeries, over 200 hospitalizations, and 3 amputations, and 15 times of being in septic shock and in a coma because of the septic shock. And because of that, I have shared my story and how to use my use stories to move healthcare forward. Thank you.
Thanks, Rosie. And Deb.
Deb Wackenheim. I'm a senior project manager at Open Notes with Kate, and have had the pleasure of doing some work and interacting with folks at PFCC Partners over the past few years. So we're really thrilled to have this opportunity.
All right, thanks, Deb. Brittany, if you can share the slides, we'll get started.
Are you seeing them still?
I don't see them, but that could just, oh, you know what? Because I didn't have the right thing selected. Okay, starting over. Thank you, Brittany, for sharing the slides.
No problem.
Before we get started talking about the project, I'm going to just spend a minute to make sure that we let you know like how we talk about some things to make sure that we're just being clear. So we call a person who helps someone else manage their own healthcare, as it could be a family member, a friend, another trusted person. We call that person a care partner. The patient portal, I think you're probably all aware of the patient portal. It's a secure platform through your healthcare system that allows you to look at your record and message with clinicians and a bunch of other kinds of functionalities. So when a care partner has access to that person's chart, we call that shared access to the patient portal. So the care partner has their own login information rather than logging in through the patient's login and password. And then we'll talk, you're going to hear me use the word co-design in this presentation, and that's just the process of working in partnerships with others in the community. And in our case, the community is older patients and their care partners, along with clinicians and health informaticists, so people who work on health information technology. Next slide. So why are we even talking about shared access to the patient portal? So this is where, as I mentioned, a care partner could log in using their own credentials rather than what often happens is they just are logging in using the patient's login name and password. A lot of people in healthcare know about shared access, but they think of it only as something for children. So it's only something in pediatrics rather than something that could also benefit adult patients. And we don't use the word proxy because we found in our work that it was confusing to people. It got confused with things like healthcare proxy, which is a legal term where someone else makes decisions for the patient if they're not able to make those decisions for themselves. So we use shared access instead. Next slide. So shared access can be particularly useful for older adults because it allows patients to identify in sort of an official way who is involved in their care. So it really legitimizes the care partner involvement and makes the care partner visible to the healthcare system as someone that is helping the patient. So in that way, it really provides a lot of transparency. It allows the clinician to know who they're interacting with over the portal. They're not having to guess, is this the patient? Is this person not the patient? Do they have the patient's permission to be in the record? So that can be confusing and a little worrisome for clinicians, especially when there's kind of bidirectional communication, or if the clinician and the patient / care partner are discussing something that is related to legal documents or patient-reported outcomes. Finally, some portals do also allow patients to determine what the proxy can see, what the person with shared access can see, but generally, that's a pretty underdeveloped function. Next slide. So we were in a review of the literature, we're noticing that the rates with which care partners had shared access to the patient portal was very low. So we were funded by the John A. Hartford Foundation to create a project with 3 clinical sites. You'll see that's the University of Utah, University of Rochester Medical Center, and Providence Health Systems, to create co-design a project that was aimed at increasing the registration and use of shared access for older patients, so patients who are over age 65. Next slide. We worked with the sites, with both the patients, the care partners, and the clinicians and staff to design this sort of workflow for how could this work in a practice. And this is a general description, what you're seeing here. The sites, each site did it a little bit differently. So one site, for example, mailed a brochure about shared access to every new patient before they came in for that first visit. And sometimes they would bring it up on an appointment reminder call. We had posters and brochures that were available in the waiting room and the front desk. I'm going to show you an example of that. We had a script for whoever was doing the rooming of the patient to help them to bring up the idea of shared access if they thought that it was appropriate for a given patient. When the clinician was in the room, we had scripts for clinicians, kind of talking points, how to bring this up. We also had something called a smart phrase that allowed clinicians to just put information about shared access right into the patient's after visit summary. And then at checkout, there was both the brochure again, but in some places they actually had a staff person who could help that person sign up. So that's how the project worked, and each site implemented it and tried this out for a year. This next slide is an example of our co-designed educational materials. So this is a poster that's in both in the waiting room and in the patient rooms. And through our co-design process, our group landed on this idea that they didn't want pictures on the poster or in the brochure, because they felt like as soon as you put a picture in, it became kind of exclusionary. Like people would look at it and say, well, that doesn't apply to me if they didn't look like the group in the picture. So they really liked this idea of people remember less than half of what their doctors say. And then why would my chart make that easier? And why is my chart proxy important for that? And I did hear this is the University of Utah. And when I went for a site visit, one of the clinicians told me that more than one patient joked with the clinician about how, well, I'm not going to remember anything you say anyway, so I'm just going to look it up on the portal. So we do have some evidence that the posters and on the next slide, the brochures were helpful in kind of starting conversations between patients and clinicians. And this brochure, if you imagine a trifold, on the front page was people remember less than half of what the doctor says. And when you open it up, it shows here's how to set it up with information about how to get online to do it, who to call if you needed help, and then what you could do with MyChart proxy access, and kind of a call to action, like who would I like to give this to? Next slide. So this intervention ran for a year, and what we monitored we got data each month from all of the sites about what was happening, and we found that while new shared access overall didn't really increase, it stayed, we saw small incremental increases, not an overwhelming result there. But for patients who were newly registered for the portal, they were twice as likely to have a care partner registered. So for existing patient portal accounts, it was hard to get people to switch to using shared access, but for new accounts, people were much more likely to use it. We also tracked what what functionalities they were using, and found that we saw real, great uptake around logins, results viewed, and clinical notes viewed, while at the same time not seeing much increase in messaging. So clinicians were, of course, concerned that this would cause just a deluge of messages, and that did not happen. Our shared access uptake there was greater uptake in practices that were specifically geared toward older adults. So our geriatric practice and our geriatric oncology practice. The primary care practice that serves all patients, we saw lower uptake there. And finally, many care partners reported the use of patient credentials. And we're going to talk a little bit about that when we get to Deb's piece of the presentation. But for now, I'm going to turn it over to Rosie Bartel to talk a little bit about her experience with shared access to the portal, and what worked, what didn't, and how it was helpful.
Okay.
Go ahead, Rosie.
Hi. Well, early on, I said that I had experienced septic shock 15 times. And when you're in septic shock, you're always in a coma. And one of the first comas that I was in was a 6-day coma. And my husband had been told that I was probably not going to have my mind, or my kidneys may not function when I came to, if I came to. And yet that was what he was told by the doctor. But yet, if he wasn't there when the doctor came to see me each day, he could not get information from the nurses, and he did not have access to my portal because I had never given him my password, and so he didn't have access to my portal, and so he was really in limbo for many, many days, and those 6 days, and he didn't know what was going on. He would come in, and I'd have 13 IVs, and my hands would be tied because I was like trying to pull them out, they said, but he realized that I was just trying to get the tape off of my chest because I'm allergic to tape, and I was trying to pull that tape off. But he tried to explain that to the nurses, and they didn't hear him, and he felt like he was in limbo. And so after that incident happened, we both made sure that we had shared access or proxy portals and for each other. And for me, when my husband was diagnosed 5 years ago, in 2020, he was diagnosed on June 26th with bone cancer secondary to other cancers. And so he had multi-cancers, and they were all terminal, and they gave him a very short time to live. And his portal messages were such a comfort to us, not only during the time that month. He only survived a month. So from June 26th on July 28th, he died. So in that month, though, we saw the doctor many, many times, almost, twice or 3 times a week. And yet the message from the doctor wrote about how we were, the decisions we were making and how those decisions were good. And the fact that, David was working with his family to make sure that he could die at home, and those kind of things all helped us when we were grieving. And one of the things I wish that we could do is, nobody told me they were going to turn off the portal at some point. Within a month's time, they turn off the portal. And I would have made a copy of that portal because of the messages from that portal, because the doctor's summaries were such a comfort to us. And so it's not always just what they say, but, like he would say things like, David needs Rosie, and Rosie is a great care partner for him. Those kind of things, and the decisions they're making together are the right decisions. And he would just say those kind of things, and it meant the world to us. So, not having shared access to having shared access was a great, because he had his own, I had my access to his portal. And after the next times I was in comas, he had access to my portal. And so it was a much better situation. So I am such a proponent of shared access. And it's interesting because right after this, I have to leave for the hematologist oncologist, my appointment. And when we were working through this, Kate, I asked them, what do you tell patients about shared access? And they said, we're encouraging patients to be involved with shared access, to have the proxy or shared access, because we find this happens all the time. Patients end up in comas and then they don't have the access. I was in a teaching hospital where they didn't know me. I wasn't in a local hospital, and they didn't know our family like, the family doctors would have. But so it definitely is an important thing. And I hope that all of you think about doing this. Thank you.
Thanks, Rosie. As usual, every time I listen to you talk, I learn something new and interesting and inspiring. So thank you so much for sharing your story. I'm sure people have thoughts and questions or experiences they would also like to share. So feel free to use the chat, or we're going to finish up the talk in a few minutes, and then we can have, if you want to save up your questions or your comments until then, that's great. That's great too. So I'm going to turn it over to Deb now to tell us about some of the work we've been doing with a learning collaborative.
Great, thank you. So Rosie is one of our many wonderful members of our now 2-3-year-old learning collaborative on shared access to the patient portal for older adults. We just call it the Shared Access Learning Collaborative for short. But we have a variety of stakeholders in this group that meets quarterly: patients, care partners, electronic health record vendor representatives, clinicians, healthcare staff and administrators, et cetera. And we all come together to kind of talk about experiences with shared access, how to promote shared access, how to disseminate some of the learnings on shared access so that more people even know that this is an option for adults. Next slide, please. So one thing that came out of this group that I wanted to briefly touch on is that we did, yeah, you can just put them all up, sorry. We did what we called a secret shopper exercise with the group, where we asked people, they had a few months to either try to give access to someone else, someone who they trust to have access to their portal, or have someone who would want them to have access, try to give them access. So we had 18 people from the Learning Collaborative, 24 responses. So, they might have tried to give a couple people access or vice versa. 17 different EHR vendor portals. Most of them, I think, were Epic, but there were also some Cerner and Athena, which are some of the big vendors in that field. 9 of them tried to give someone else access to their account, and 15 people tried to get access to someone else's account. And as you see in that box on the right, 8 of them did not happen. And you'll see in the next slide a variety of reasons people reported, and 14 of them were successful. So we had people try this and then fill out a brief survey answering some questions so that we could get a sense of what worked well and what maybe did not work so well. I can tell you from personal experience, I tried to do this with 2 other family members and all at the same health system, and it was different in each of those 3 cases. So it was very interesting. Next slide. Oh, and there are 5 successful attempts, sorry, took more than 1 day. And some of them took many months or never happened at all. Okay, next slide, thank you. So what we've seen is that, you know, there's a mix in terms of how people are able to do this process. If I as a patient wanted to give my partner access to my portal, depending on the health system, it might be, as you see under one of the barriers is forms. It might be there's a hard copy form that you can only get at the office, or you can have emailed to you and you have to print and fill out and have wet signatures, not electronic signatures, and mail it in or bring it in. So obviously that, I mean, that's how it's been for many years, kind of old school. But some places have been very reluctant to change that, sometimes because they have legal concerns about changing it. But that's much more burdensome, especially if I have an adult child, maybe in Los Angeles and I live in Boston. That would then obviously take some time to get that whole process done if I want to give them access. Another barrier that people saw was technology, where they go onto the portal and then they have no idea how to start this process. Maybe there is an electronic process, which does make things easier if you can do it through the portal, but it's not at all obvious if there is one or how to get it started. So they might not have any information on their website that they even have this option, or they might say, yes, there's an option. And then you go into the portal and there's no information about where to go to start this process of sharing access with someone. Or there might be multiple verification steps, et cetera. So there's the technology barrier, there's the form barrier, and then access. So a variety of things over here, but things like lack of staff training, where a lot of the staff don't even know, and I encountered this, that an adult patient can give someone else access. They told me that's just done in pediatrics. And they actually said, just give them your login credentials, which they're not supposed to say. I did not chastise them at the time, but in my head, I was thinking, no. Lack of information on the website. You need a phone call back. Takes a long time to call back, only during business hours. If you're at a job where you can't really make those calls and be sitting on hold, that makes it difficult. Creating a patient account, that's often a pretty big barrier, where if the person you want to give access to is not a patient in the same health system as you, the system either just, it doesn't work. They say we can't do that, or it ends up being jumping through a lot of hoops, which of course then just makes it frustrating and people will often give up. And then the privacy concerns, where, and I saw briefly someone in the chat said, is there a way to kind of give different levels of access? And there is some concern for some people that they don't necessarily want to give all of their information to a given person. So we've been encouraging the EHR vendors and the health system to think about having graduated levels of access, where, like, I want my child to be able to see the billing and maybe my upcoming appointments, but not a lot of the details in the records and the notes, that kind of thing, because some people do have privacy concerns about sharing. Next slide, please. So, and this, we're looking forward to the discussion, and we can talk about some of this as part of the discussion, but what we see as some of the need out there is really raising awareness, both among patients and care partners, that adults can have shared access, adult patients can share access, why it's beneficial and how to do it, which of course might vary across systems, but it would be great if it was standardized, and raising awareness even among the staff, clinicians, and health systems that adults can do this, and why it's beneficial and how to reduce the barriers that they might face. And then the next slide is just, I think, the coalition. So just want to let you know about this website, where we have a lot of information about this work, as well as some other work we're doing relating to health information technology and care partners. So I encourage you to go on there. We also have these toolkits, which I think might be particularly interesting to this group. We have a patient and care partner toolkit. Great. I think that's it for us. And feel free to contact me if you're interested in joining our learning collaborative or hearing more about it. Feel free to sign up on that page or shoot me an email.
All right, wonderful. Thank you all so much for sharing. So now we are going to dive into some discussion and thinking about our call to action as well, based on what we heard. So we'd love to open it up. You've heard from us, and now we would love to hear from you all. So a couple questions to think about to spur discussion. Also, there's some things in chat as well. But what is something that you learned or that you found interesting today, or something that made you think? And then how can our community best support care partners? So thinking about that. So I will pause for a moment. And again, I know I saw a couple of things in chat. So feel free to share. Nadine, I know you put a couple things in. Do you mind coming off mute, Nadine, and just speaking to those a bit?
Not at all. You know yourself, it doesn't have to be an elderly person. I mean, I'm elderly, but anybody of any age could be wanting to withhold something really critical to their care and the success of healing, and they don't want the doctor to know. And if you had a care partner who observed something that would be so important, how do you do that, you know, without legalities or whatever would be the roadblock to coming up with a better result.
Mhm.
And I personally, I'm a real, well, doesn't Libby know this? I am such a graphics person. I think it really, I mean, were people really that insulted if it didn't depict them? I mean, like Microsoft's, I can't think of what it's called now. Well, they all have the AI where you can give a detailed depiction of what you want them to draw, and they can make it as inclusive as possible, and you know, more like a cartoon versus photo. I use it all the time. It's the coolest thing, and I just think graphics is such a great way to capture some interest in doing this. That's just my personal opinion. Also, I think that if you painted a little scenario of things people wouldn't necessarily think of, like, oh my God, I'm not going to be in the mood to want to maintain the portal or check back. And yeah, it's a great idea to have somebody else. It's anything in life. It's nice to bounce
Mhm.
something off someone else. It just, if you just really drive home some real simplistic point, it might contribute to the success of this.
Thanks for that comment. Just to your question about the graphics, we started out in the design with photos, and it was interesting. Our 3 sites were not, one of them even explicitly said, like, this is not in line with our diversity and inclusion policies. So we're really moving away from photos. So try to get a catchy, kind of a catchy catchphrase instead to use.
Oh, I love taglines too.
Yeah.
Taglines are just as successful. Yes. Yeah.
And then for your other issue, it is really tricky. In the case of, and I mentioned this in the chat, in the case where it is an older patient, particularly, it comes up quite a lot when the patient has cognitive issues, like they're experiencing, early stages of dementia or other cognitive declines, and the care partner might use the portal as a way to say, hey, this is going on. I don't want to bring it up in front of my wife because it'll be very upsetting, or it's embarrassing, or but kind of letting the physician know. In cases where the patient, though, does not have any cognitive issues, it really is a balance of kind of, the clinician really has to decide, like, how they really have to first consider from the patient's perspective around their autonomy. So even if the care partner did send something that the patient doesn't want the clinician to know, it becomes like a sticky, delicate situation for that clinician. And really, I think there is no kind of best practice around it that could be universally applied. It's sort of a patient by patient kind of considerations.
Yeah, I appreciate that, certainly.
Can I make a comment? I
Mhm.
can't find my raise my hand. I'm on
Go
my
ahead,
cell phone.
Beverly.
I use my portal all the time. But what I have found living in my senior community is that a lot of folks don't use their portals, not only because of the things that we've discussed, but some folks don't know how to type. It takes them so long to do it. And with new technology, it would really be nice, just like we can speak into our phone for a text. Somehow, uh, they need to be able to speak it into whatever the portal is. Because if they can't type or they can't write or they're having vision problems or they're having other issues with just using the portal or other than the whole, mechanical piece of it, how do we get the healthcare system to realize there are people who don't write, who don't think, who can speak it, but can't write it?
Mhm. That's a really great point about just the accessibility of the portal overall, which is poor. They're not that well designed. You have to be fairly computer literate to be able to use it. In that case, the care partner can be sort of a band-aid solution, for the overall poor accessibility of the portal, but a better solution would certainly be a more inclusively designed technology.
Thank you so much, Beverly. Great point raised. Thank you. I see a couple raised hands. So Karen, I saw you first, and then we'll go to Ray, and then Rosie will circle back around to you. So Karen, go ahead.
Thank you. I think this shared access is wonderful. And I've been a nurse for many, many years and a healthcare consultant. And this is the very first time I've heard that shared access is available. So I've never heard a nurse in any of the hospitals I've worked with. No one has ever mentioned this. So I think education of the care providers is very, very important. And I think it's a very good supportive tool. But I want to, now I'm concerned for another thing. I just got a note this past week that they're going to be charging money for my access to my portal, depending on, the length and so forth. So that's going to, some people are very short in what they have to say and others are not. So we have to be cognizant of the fact that there may be charges for their dialogue in the portal.
Yeah, that's something that some healthcare systems, not all, a few are trying out as a way to reduce the number of messages reduce the number of messages and the complexity of the messages that the clinicians are getting, because they're generally not reimbursed for time that they spend reading and responding to messages. And then another thing that we've heard is that sometimes we as patients are using the portal in the way that we would email. So it's if the doctor writes back to you and gives you, an answer to your question, I might write back, thank you so much, that's very helpful. They don't want me to write back and say, thank you very much, that's so helpful, because that's just another message that they have to read. So I think we need to do a little bit more for patients and care partners to really understand, like, what's the best way to use this so that you get the information that you need and your clinician isn't answering your message at 11 o'clock at night. So we need to the systems. We designed the systems for a poor result, I think. So thinking through how do we really want these systems to work would help with that problem.
Thank you. Ray, I'll turn it to you. And then Rosie, and then Jean. I see your hand up as well after Rosie. Go ahead, Ray.
Yes, thank you, Brittany. I'm fortunate enough to work at a facility, Rancho Los Amigos National Rehab Center, where we have a designated resource center in the hospital, in the rehab center. And before that, I was working as a peer mentor as well, working with families and individuals while they were in the hospital. And we saw a need for technology learning as it's growing, and maybe a lot of elders or people that are not too tech savvy needed assistance. And when the portal rolled out, there was a big disconnect with the people that didn't have that background in technology and learning how to navigate. So we created, I personally took the initiative of creating an all things web class to learn the basics, navigate email, and also help with the portal. And that's where the resource center came in handy because there was a designated location where people could know that they'll be heard and not rushed to learn something, and also could visit back to refresh themselves and learn another part of the portal, especially as there's so many submenus and options in there. It's hard to just do a crash course. They could get overwhelmed and maybe shut down and stop using it because they could feel they're a burden or some kind of, too much for them to be coming back and relearning stuff. But I found out that that was very effective, and the patients really appreciated that someone could be there for them to spend 30 minutes, an hour, whatever it took for them to start wrapping their heads around using that and having better communications with their physicians.
That's amazing. Well, this was an in-person resource that was offered, or how did it?
Absolutely, absolutely.
Yeah,
So
no, I would think it would have to be.
yeah, the resource center is run by peer mentors.
Mhm.
And the peer mentors are designated to sit down and take as long time as the patient needs after or before their appointments at the hospitals, to know that, you sit there and as long as it takes, we'll guide you through the steps, how to read your doctor's notes. I mean, all the menus and options that thing has, and yeah, it's been working pretty good. But again, not all facilities have that option, but that's something I uh, suggest, and also in case hospitals or big facilities are getting remodeled, right, or updated, and they build out hospitals, be a good idea to incorporate a small room or at least a location of a resource center, because then it takes the pressure off staff, right? Like nursing, and because they also have limited time they could allocate to help people learn about navigating the portal. But yeah, that's just my 2 cents.
Thank you.
Thank you, Ray.
I also commend you because, when I think about how I learned about my portal was by step by step by step. I first, looked at lab reports, and then I looked at, at first there wasn't notes, and then there were notes, and, I've been working with open notes from pretty much the beginning. And so I did this step by step to learn about my portal. I work with Epic on their patient and have been involved with their patient advisory council from the beginning. I helped them form it, and that advisory council meets monthly, and it's definitely a place where I can take your concerns about the. I know that we brought concerns about the people with that had lost their vision, individuals who had lost their vision, because their free apps didn't work on the portal at first, but they worked with Vision Forward from Milwaukee to make sure that it got solved, and now those free apps work on their portals, and so basically, your idea could become, it could happen. Your idea about having a place that you could just speak into the, like the message or asks for, could you tell me about my labs, or could you read me the summary? Because I think many times people, we don't know the literacy ability of families and people, and or read it in my language, might be another thing that could happen. So they're always bringing new ideas to us before they now create things in the portal. They used to come to us and say, here's what we think we should do. And we tore it apart so bad that now they come with their idea first. And then we tear that idea apart and they get lots of information from the patients. There's, several, Connie Montgomery's on it, and I am, and lots of people that, when COVID originally had started, that it was in person, and all the people were from the Madison area of Wisconsin. And I drove 2.5 hours to go to that meeting. And I was the only outsider but now we have people from across the country. We have people from every walk of life and every race, color, creed. We did a lot of, I brought a lot of people to the patient advisory council. So it's really, and shared access has been, not a big topic for them, because I think they did all the barriers that we talk about. And I know, I have 6 my charts, 6 different my charts. Now they all come under one place now, but they all have their own system. And if, so you have to be a patient in almost all of them. You have to be a patient in that system. And that's really, that one needs to go away, because my son lives in Arizona, but I'd like to have him to have shared access, because if something happened to me, he'd be the person that would be first at my steps. And yet he can't get shared access to anything of mine. So, that is a barrier that I encounter every day, because one of my kids has shared access to one account, another one has a shared access to another account. When I had my husband, that was a better situation. Now I don't have him, and so it's gotten to be a whole lot worse. Thank you.
Thank you for sharing, Rosie, and for your continued advocacy in many different ways to keep sharing the message. So thank you. Jean.
First, I want to thank Kate, Rosie, and Deb for presenting and also advocating for this, because awareness is the first step always. And I guess if I wanted to raise awareness, at least in my local community, our 18-year-old just finished school and will start college in the fall. So a lot of parents are going through oh, they're suddenly an adult, but they really aren't. And we ran into our first hiccups with medical access, school portal access, and everything, because she turned into the adult phase. So I think shared access is a really productive way for us to advocate for her. I mean, she's not really all that grown up to go do all these things by herself. So I think I'll bring it up to our parent committee. And I guess something I really took away from this is that there are 2 sides to this ecosystem: doctors, clinicians, advanced practice providers, nurses, everyone, and then patients. And if we're feeling strains around shared access, how we communicate with one another, how we perceive each other's communications, maybe this really boils back down to a product design, discrete data point choosing process. So if we wanted the doctors to walk away, I know someone gave the example of doctors receiving too many messages, right? Too many thank yous, too many tail ends, and they have to review it anyway because it could be a clinical message. Even starting with a kudos button after a patient's, worries are addressed, a kudos button that, sends out a report at the end of the week. Hey, doctor, you received 25 kudos from your patients this week. Then it doesn't ping them, but it tells them at least once a week, things are going good. So this might really be a tech enablement, tech design related conversation with our enterprise partners. And I know I can kind of bring that back to some of my circles, but this was really productive, helpful, and timely, especially for our families. So I'm excited. Yeah. Thank you for sharing, everyone.
And Jean, thanks for mentioning that when the kids turn 18 piece. I think that is an interesting group. I have a 20-year-old, so I was like, yes, I totally get it. But that is an interesting group to target. I mean, the funny thing is, if the now 18-year-old adult does give you permission, you actually have a lot. You actually, well, mine did, just because I do manage a lot of her stuff. I actually now easily have access to a lot more information than I did when she was 17, right? Because they restrict it so much more in their adolescence. So that is an interesting, group to target with the shared access information.
Yeah, I have a son and daughter, and the daughter she was basically born capable of managing all of this. And my son may never be capable of managing it. So it's such an individual choice. And it's such a funny time of like, well, I want to be independent. I'm trying to launch myself as an independent adult. At the same time, I still need your help. So yeah, that's a really good time to be talking about this issue as things turn, because I think also our young adults are still kind of expecting us to manage some things for them. I love your idea of the kudos button for a couple of reasons. One is that it allows patients to say, hey, I read this and I'm all set, without it having to be something that the clinician has to read. But it also is giving the clinician the positive feedback. And in other studies, I have heard physicians say that they save messages. Sometimes they'll save like a really nice message or a really, a really great interaction just for like when they're feeling low about their work. So the kudos would be a way of like giving them that without adding to, the messages that they need to look at, which for a clinician is a lot of time that they don't necessarily get paid for if they work in a system where they're still being paid, on a per visit. What services did you deliver during this given visit? So sometimes the portal access is, I think, designed for a system that doesn't work the way our healthcare system works, and that creates a lot of friction.
Miss Kate,
Yes.
this is Beverly, who did not raise her hand. I apologize. I don't even see it on my phone.
Don't worry.
When you were talking about a certain button, that what I did the last time, and I realized that I was having a back and forth conversation with my physician. I finally said to her, do we need to have a virtual visit? So maybe there needs to be a button or a limit to how many questions or where the conversation is going. And either one of us will say, there needs to be a virtual visit, or we need to talk about this, or can you call and make an appointment?
Yeah.
So that there is an end in sight, because I don't like sitting and waiting for her to answer me either. So that might work as well.
Mm-hmm. Yeah, I think we all need training on how to use this in the best way possible, and not use it as we would normally use email communication or even texting communication. But this has its own distinct style that could really help.
I think also when there is a lot of suffering happening, especially with our elderly patients, really progressed patients, sometimes there is a lot of over speaking where you don't actually know the patient's perspective, either because their children, their adult children are over advocating, or they haven't had a transparent conversation. I know with my mom, we just had a really completely unexpected conversation when our younger kids were out of the country for another reason. I've never heard my mom speak to me with such honesty and clarity. So if we use the shared access where a physician can be a mediator for independent perspectives to be submitted to him or herself, and they can get an honest take and just kind of disclose what's appropriate for coming to a better path forward for both patient and family members, caregivers. And I think there are really balanced and nuanced ways that this can be brought on board for different stakeholders.
And I have also in other work focused on dementia heard clinicians say that they like getting those messages. They like getting them in advance of the visit because it helps them prepare. You know, what are we going to talk about? How am I going to handle this? Rather than the post-it note on the door, or can I talk to you in the hall, which is not an efficient way for them to be doing their work either. So they like that. So if we could think of how we can encourage more patients to grant a care partner access so that these kinds of conversations can happen, I think that's helpful for everyone.
Absolutely. Thank you. Thank you. This was such a wonderful discussion. We have only about 3 minutes left in the call. So time flies when you are having fun, when we're having such engaged discussion. So thank you all so much for sharing so candidly and for your great ideas, both verbally and also in chat. So much good stuff coming in chat as well. So we are very appreciative. Thank you all so much. I am going to share just a couple of quick slides for a few announcements. But Kate, Rosie, Deb, thank you so much for this wonderful and very helpful presentation, and just for sharing back with us, and for all of you participating and being engaged and sharing as well. So let me share my screen. Libby, while I'm doing that, is there anything that you wanted to say? I know we're about to kind of round out coffee chat and shift gears, so I just want to give a quick opportunity if there's anything that you wanted to share as well as our fearless leader.
No problem. Yeah. Kate and Deb, Rosie, thank you so much for your sharing this important work with us. And I loved, similarly, I had the mindset of shared access being, I'm thinking of my father-in-law, and wouldn't that be awesome if I could get, into that. But Jean, you bringing up the transition years, which are so bumpy, right? How fantastic that would be as a support of the relationship moving forward into adulthood. Whoa, I would have loved that. So I just think, as always, we're thinking in so many different ways. Ray, I love that you're bringing forward the way that Rancho works with its patients and family caregivers, because I do really think it sets a standard. And although it's highly relational, I think that learning from those highly relational kinds of programs can better support the development of technology to support relationships. I think that's what we all want, right? We want to use technology in a way that supports the relationship rather than replacing it. And I think this has been a great conversation. So thanks to all of you.
Thank you so much.
Thank you, Libby.
Mm-hmm.
Thank you very much, Libby. And I have to go off to a doctor appointment, so I'm going to not
Good
be
luck.
your next discussion.
Well, good luck.
Okay, thanks.
Have a good day.
Thank
You
you, Rosie.
Thank you all. Have a great rest of your day.
Thanks,
Yep, have a
Kate.
good
Thank you, Kate.
Bye.
Yes, as mentioned, we are going to continue this call for those who are able to stay on. So I put the link in chat for Putting Care at the Center. We will be there in October. We will continue to share about this, but registration is open. As always, you can connect with us on the forums. We're constantly posting some great things on the PFA Network website forum. So please visit us there to keep the conversation going. And then also refer a friend. I know so many of us know people who could benefit from these conversations. So I will drop a couple of these links in chat, but they are continually coming out in our newsletter, on our website, PFAnetwork.org. So you're able to see all of these as well. But yes, continue to tell your communities about the PFA Network.